Thank you. Actually, this instruction course is courtesy Dr. Mayuri Khamar, who is not able to come here. And, I interpreted the topic a little differently. And my interpretation was that the fields are narrowing over time. That is, the disease is progressing. But what else do we need to keep in mind as a possibility for the glaucoma progressing, and what else could be an artifact in this thought process? So I think our goal in glaucoma or any other disease actually is to improve the health of the patient as a whole. And for this, we as clinicians need to give appropriate treatment, balancing the need for treatment and the possible side effects of the treatment. So we all know that blindness in glaucoma is the rule. It's just a matter of time, and our treatment only delays that blindness. And hence, detection of glaucoma progression is crucial for identifying those at risk for visual loss. So there cannot be and will not be a consensus as to what progression means in glaucoma. So if you look at definitions for glaucoma, they come from clinical trials, and there's always a clinician's perspective. So if you look at this, 40% of the retinal ganglion cells need to be lost before you have a demonstrable change on perimetry. These changes happen earlier, and nerve fiber layer changes happen there. So previously, the accepted norm was that structural damage to the optic disc will precede functional loss on visual fields. The OAT study, the EGPS, shows that structural and functional changes need not coincide in patients, and some patients in the ocular hypertensive study convert to glaucoma. So the OATS and the EGPS study found that disc changes happened first, but in the EMGT study, changes in the visual field happen first as compared to disc changes. Now, if you look at the advanced glaucomas, the AGS study, they did not have a disc outcome. They only focused on assessing function based on visual fields. While the CNTG study, that's the collaborative normotension glaucoma study, had focused on disc and field changes. So other studies have shown that visual field changes may precede the development of optic disc changes. Now, from a clinician's perspective, currently the gold standard is to document a structural change to the optic disc as a functional loss on white or white perimetry. And white on white perimetry is also the gold standard to assess the rate of progression over time. So if you see these two patients, we all know that all patients will not progress at the same rate. And if you see the figures, patient A is unlikely to achieve critical loss of vision during his lifetime and does not need aggressive treatment. So what exactly is progression on perimetry? When a new defect appears in an area which was not involved earlier, there is a deepening of a pre-existing scotoma, or there is an expansion of a pre-existing scotoma to involve new areas, or suddenly you have a generalized reduction in sensitivity. So it's important for us at this stage to differentiate between progression and fluctuation. We need to identify the extent of change that has happened, the areas which are involved, and also know the rate of progression. So for glaucoma patients, if you're a Humphrey user, a central 30 or a 24-degree test is fine. If you're an Octopus user, a 32 or a G1 program should suffice. In advanced glaucomas, if on the Humphrey you'd like to use a 10-2 or a macular program, on the Octopus a 12-degree works equally well. Most tests on the Humphrey should now be done with the CETA standard. That should be the norm for all of us. On the Octopus, you could use a top or a dynamic strategy. The frequency of testing will vary depending on the severity of the disease. So first step is form a baseline. And 2 visual fields over 12 months is fair enough, even though studies recommend that you could do 2 fields in a month's time. But remember, it's an out-of-pocket expense for the patient. Advanced glaucomas, you could come back and do 2 visual fields over 6 months. And then periodically monitor the patient with visual fields done, say, once a year for patients with early glaucoma, once in 6 months for moderate, and every 3 months for patients with advanced glaucoma. The frequency of examination can be varied. Let's say the patient has a fluctuation in intraocular pressure or develops a disc hemorrhage. Then you can come back and do your fields more frequently. Then there are confounders to assessing progression. For example, you cannot compare the visual fields done with the Humphrey with that done of an Octopus machine. You cannot compare the visual fields done on 2 or 3 different Humphrey machines together. Similarly, fields done with the octopus, different machines cannot be compared. And then one needs to get good baseline fields. A good baseline visual field is a reliable visual field with not more than a minor fluctuation in the mean deviation. We must keep the learning curve in mind. We cannot compare visual fields done with different programs. We can only compare fields done with similar strategies. So you can't compare a full threshold with a CETA standard or a CETA fast with a CETA standard. We cannot compare fields done with a stimulus size 5 with a stimulus size 3. So beware of these anomalies that can happen. So avoid confounders while assessing progression. Use the same program, same strategy, and the same stimulus size. Almost always use software for progression analysis. And software will work in 2 ways. It would be event-based, which would help us to compare with baseline, and there would be a trend analysis to assess the trend, which would give us the rate of progression over time. Now, this is the case profile of one of our patients, a 52-year-old gentleman who came first to us in 2003 for a second opinion. He had been diagnosed to have glaucoma because of a raised IOP. He was on blood thinners and had an altered lipid profile, no allergies, and he was on treatment with latanoprost and levobrinolol containing eye drops, no family history of glaucoma. The best corrected visual acuity was 6, and N6. Applanation pressures, cornea adjusted, were 18 and 16. Shallow chambers, discs were normal with healthy rims. Gonioscopy showed occludable angles, so our working diagnosis was primary angle closure. We went ahead and did a laser iridotomy, and on subsequent follow-up, his pressures remained between 14 and 16 millimeters of mercury. We got the visual fields done. This is 2004. The fields in the left eye were normal and the right eye was normal. Again, re-emphasizing our clinical examination that the optic disc was normal. Patient continued to be on treatment and came back in 2015 when we felt he had developed a mild pallor of the optic disc. Pressures at that time were 13 and 15 millimeters of mercury. We did the visual fields. In the right eye, there was a small change that you can see close to the blind spot here. But at that point of time, we did not consider it significant and disregarded our observation about the temporal pallor. The mean defect, when in 2015, when we did the trend analysis, we found that in the right eye, the diffuse defect had shown a small drop. But you know, many of us, when we look at this, would consider it as not being significant because in the software, the statistical analysis markers were not signifying that this was significant. Patient then came, this was January 2015. Patient came back again subsequently having blurred vision, and in the left eye we found there was a much more temporal involvement here. And this time we asked for an MRI. And when we picked up the MRI, we found there was a large cellar, supracellar, and a right paracellar region elevating the optic chiasma and displacing the right cavernous artery. So the fields were done. He underwent a neurosurgery. Fields were done, and this depression here that we were seeing in the left eye had got better. And when we did the trend analysis, we found that in the left eye, the depression that was happening has subsequently moved up, implying that the compressive effect has disappeared. So we talked in the initial examples of how a glaucoma patient need not have a glaucoma and it could be a neurological problem. I'm showing you here a glaucoma patient, an established glaucoma patient on treatment who went on to develop a neurological problem. So just because the fields are narrowing doesn't mean glaucoma. It could mean glaucoma plus something else. And this patient had developed a new disease, a neurological disease. So remember, life expectancy is on the increase. More and more of our glaucoma patients are going to live longer. Neurological lesions like age-related atrophy, cerebrovascular lesions, age-related macular lesions are also going to increase. So we need to rule out non-glaucoma related progression in a patient with glaucoma, and we must not miss a new neurological disease in a patient with an established glaucoma. Thank you very much.